welcome once again to this program, Health Matters. This is ABN TV hosting. This program is coming to you directly from Nigeria, Osun State. With me here is Dr.
My name is Dr. ADELEKE.
Good morning, sir.
Good morning, viewers.
Nice meeting you on the program.
Thank you very much.
Yes, the topic we are talking of today is diabetes mellitus. We just want to know what is the meaning of this disease.
Okay, thank you, the anchor. Diabetes mellitus is one of the chronic diseases. By chronic diseases, we mean it's a kind of disease that stays in the body for a very long period of time, and it's a non-communicable disease. Non-communicable disease because you cannot contact it by contact with another person, either through sexual intercourse or coughing or exchange of blood and all that. So we really cannot contact it through it. So we call it a non-communicable disease. And then to be specific now, diabetes mellitus is a disorder of a particular hormones. Hormones are small chemicals which the body produces. So the name of the hormone under question now is insulin. Insulin is produced from the pancreas. Okay, the pancreas is located within the abdominal cavity. This pancreas secretes these smaller hormones which we call insulin. And the function of insulin is to convert glucose. When you and I eat all sorts of things, be it rice, be it garbage, be it any kind of food that we eat, the body will automatically convert it to glucose.
Yes.
Okay, so the glucose will be useful to the body, but the other ones, the excess of it, need to be stored up for future purposes. Now, this insulin hormone is the one responsible for conversion of this glucose into the storageable one, or the storageable format, which we call glycogen. Now imagine when you don't have this insulin, that means you have a lot of excess glucose all over the body, all over the bloodstream, and that is the how will I put it in a simple term, in ABCD of diabetes. When you have excess of glucose in the blood,
Yes.
as a result of either absolute or relative deficiency of that small hormones which you call insulin. So that is the definition, or that is the simple explanation of diabetes mellitus. Thank you.
Thank you, doctor. Yes, we are all aware of this diabetes mellitus. They are of different types.
That's correct.
But please, can you just name them and shed more light on them?
Okay, thank you. Earlier on, I said from the explanation of the diabetes, that there is either relative or absolute deficiency of the hormones, which we talk about the insulin, as the cause of diabetes mellitus. Now, this deficiency, from that premise, we can now classify it into type 1, type 2, gestational diabetes mellitus, and others, which I'm going to explain.
Yes.
For type 1 diabetes mellitus, there is absolute deficiency of insulin, which means there is no insulin at all being produced from the pancreas. We usually see this most of the time among the children. Before age 1, age 2, age 3, age 4, age 5. That is when we normally pick them. If a young baby should come to me with symptoms in keeping with diabetes, which we are still going to talk about, most likely I can put my money on it that it's most likely going to be a type 1 diabetes mellitus. In them, there is complete absence of insulin hormone in them, so the body is not producing insulin. So most of the time they live their life on what we call exogenous insulin. That is, we are going to be administering insulin in form of injection to them for the rest of their lives. So that is type 1 diabetes mellitus. In type 2 diabetes mellitus, yes, the pancreas is producing insulin. Is either the insulin being produced is not adequate, that's one, or is not functioning very well. And usually we see this in people older than 40, but of late we've started seeing it in people younger than that. We started seeing it in people in their 30s, 35, 34, 30.
You mean diabetes?
Coming down with type 2 diabetes mellitus, which initially we used to see it in the people older than 40 years. Okay, most of the time those people are of the big size, they are obese, they are old as compared to type 1, which they are younger kids, and they have to live the rest of their life on insulin. For type 2, not relative, I mean, not absolutely. Some of them could live on medication, whereas other people, we might need to augment them with at a point in time with insulin. But it's just a relative deficiency, not absolute, as seen in type 1 diabetes mellitus. The type 1 is what we call gestational diabetes mellitus. This is usually seen among pregnant women. Okay, a non-diabetic woman that comes to the hospital, now following the routine antenatal screening, we saw sugar in the blood or in the urine. Then we went further to screen the woman, and then we were able to make the diagnosis of diabetes in a non-diabetic patient, a pregnant woman that was not diabetic before pregnancy, but along the line develop a diabetes during pregnancy. So that is what we call gestational diabetes mellitus. Then we have the other group that we call others. Others encompasses all sorts of things that could cause diabetes. For instance, people that are on long-standing chronic use of steroid. Steroid are drugs like dexamethasone. Our girls, our ladies are beginning to use that. They said they want their breasts to be enlarged or to enlarge their buttocks. And so they give them all sort of steroid, dexamethasone, prednisolone, and also for patients, some patients that we need to give some of these drugs, especially some with some reaction, people with nephrotic syndrome, that they have to be on high dose steroid for a very long period of time. Some of them along the line might develop some of these signs and symptoms of diabetes mellitus. So when we see diabetes mellitus in such people, we tag them under others. I mean, the class 4, which you call others, diabetes mellitus. Not only that, people with other infection of the pancreas. Don't forget, I told you that pancreas is that organ within the abdominal cavity that produces the insulin that we talked about. So when they have some of these diseases affecting this pancreas, like pancreatitis, which is like inflammation or infection of the pancreas, some of them could come down with some of these symptoms of diabetes mellitus. So to recap, we have type 1, which we normally see among the younger people, and those one will require insulin for the rest of their life. We have type 2, we see it in people in their 40s, but now I told you it's beginning to come down to 30, 35, you're beginning to see it among them. And in those people, they do produce insulin, but is either the insulin is deficient, is not enough, or is not functioning very well. Then we talk about gestational diabetic mellitus, which we said we see in pregnant mothers. They don't have diabetes before, and all of a sudden during pregnancy they develop it, or it might be at the discretion of the physician or the obstetrician attending to such pregnant women. We find out that this woman is having big babies, or is having recurrent abortion, or is having stillbirth, or is having child that were born with all sorts of abnormalities. So when we see that, we want to screen for that. And if we find out that such mother is diabetic, we classify them under gestational diabetic mellitus. Then the others, which I said will occur from other things like people on long-standing steroid use and disease of the pancreas. So thank you.
Thank you, Dr. Adeleke.
You're welcome.
We are appreciating that. But the only thing I want you to shed more light is how common is this disease to the environment or to the people there?
Well, diabetes mellitus is a very, 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 very common disease. It's so common now that it has assumed a global epidemic. Is that much? The latest statistics shows that the global figure is well above 400 million people. The population of the world is probably around 2 billion, 3 billion. And then when you have almost 1/4, or let me be generous now, 1/5 of the total world population having a disease, then it's a big deal. It's a very big deal. They're coming down to Africa. In sub-Saharan Africa, Nigeria took the lion's share of this disease. It's actually very, very much. In Nigeria, the value ranges from well above 2 million people. Well above that, having diabetes mellitus. And it's so common now that before you see like 1 in every 10 patients, 1 in 5 patients are coming down with diabetes mellitus. And before now, it wasn't like this. Some 30 years ago, we are looking at 88 million, 90 million thereabouts. And now we're talking about 400 million within the space of 20, 30 years. And this is as a result of our lifestyle. Things are changing. The way people are living their lives are changing.
Yes.
People are adopting a lot of Western diets, which is beginning to affect the earth's the earthful living of individual. Prior to now, people go to their farm. They probably get their vegetables and get everything that they eat, but now everybody is going for refined foods and all that.
Yes.
Then people are getting more money now. People don't want to exercise. People don't want to walk around. I mean, when people see you walking around, your tag has been poor. Or when people see you riding a bicycle instead of a car or a big jeep, I mean, they believe you are not where to do. And all this is depriving us of our exercise culture. And these are some of the things that is linked with the high rates of diabetes mellitus that we are seeing. So to answer the question, it's quite common with well above 400 million people having this issue. Thank you.
Thank you. For viewers at home, if you are just joining us, this is ABN TV Houston. This program is coming live to you directly from Osun, Nigeria. What we are talking on now about the common disease, which we all know, diabetes mellitus. And my guest in the studio here is Dr. Adeleke. This program continues after this time out. Yes, you are welcome back. Doctor,
Yes, please.
once again, you are welcome.
Thank you.
I just want us to shed more light on the sign or the symptoms of diabetes mellitus.
Okay, thank you very much. Majority of the time, or most of the time, some patients might not even come down with the symptoms, which we call asymptomatic patients. Asymptomatic are patients that are just coming, walking in, complain, probably during a routine checkup. Like, okay, doctor, I just want to do my annual routine checkup, and along the line, you saw glucose in the urine. That would probably stimulate you to do more and go for blood sugar tests, and then become diabetic. But for those that will show the symptoms or the signs, as it were, the signs include polyuria. We call it polyuria, which I will explain, which means excessive urination. Okay, before now, maybe the individual in question wakes up maybe once or at most twice overnight to urinate, and all of a sudden somebody is waking up more than 6, 7, 5, 8 times to urinate, and then the volume of the urine becomes so substantial, becomes so significant. Like, doctor, I wasn't urinating like this before, but now I find out that I'm urinating more. And for those that are very, very careful among them, when they go back to where they urinate, they might see ants gathering around the urine. That can serve as a pointer that the urine contains a lot of sugar. Okay, then again, there is increased thirst, which will ultimately make that person to drink a lot of water. We call it polydipsia in our medical parlance. Okay, person tends to drink a lot of water. This person is urinating, is drinking a lot of water, is urinating, is drinking a lot of water. Okay, all this might be a pointer to the fact that this person might have diabetes mellitus. Also, polyphagia, the person will be eating a lot of food and will be losing weight despite eating a lot of food. Okay, so when you see this, it might be a pointer that the individual might be having diabetes mellitus. Also, generalized body weakness. It's just become so weak, so fatigued, any little activity, just get tired. It might be a pointer to it. Again, for male, they might have erectile dysfunction, which means the penis might not stand very well. The individual will tell you, look, I'm not having erection. This is not me. Before now, I used to have it. When I wake up in the morning, I'm always standing, but now it's flaccid. I cannot. Doctor, what is happening? Okay, that might be a pointer to diabetes mellitus. And then other individual might have boil all over their body, skin disease, boil all over.
Symptoms of
it could be symptoms of diabetes mellitus. Okay. Then also for female, they might develop what we call vaginal candidiasis, having whitish fluid, whitish discharge. Okay, so this might just be the pointer, and the individual will go to the hospital, for further evaluation. Now, all this that we talk about is for stable patients. Some patients, the first time they will know their diabetes is after fainting, and they were rushed down to the hospital, and after conducting 1 or 2 tests, we realize they actually have diabetes, and they are coming in what we call diabetic emergency. And then this includes what we call diabetic ketoacidosis, or what we call the hyperosmolar hyperglycemic state. I mean, these are all complications of diabetes. They can come in for the first time with all these complications of diabetes mellitus. So by and large, as an individual and as a group of people, we need to imbibe the culture of routine medical checkup, because some of these things could actually be picked early and be treated appropriately. Otherwise, if you notice any of the symptoms that we've discussed about, excessive urination, excessive thirst, you are eating too much, you are losing weight, you're getting tired easily, as a man, you are having erectile dysfunction, or you're having boil all over your body, or as female, you are having excess vaginal discharge, or you are pregnant and you are realizing, okay, look, I'm having recurrent stillbirth. Okay, first time I have a stillbirth, second time I have a stillbirth. I mean, you should ask questions.
So
diabetes could actually cause that. Or you're having a very big baby, which you call fetal macrosomia. You're having a big baby, 4.8, 4.5, 5.0, big giant babies. That needs to be done, to rule out gestational diabetic mellitus. Also, people with recurrent abortion, of course, especially mid-trimester abortion. Yeah, diabetes mellitus could actually be a cause of that. So by and large, these are some of the pointers to diabetes mellitus, which individual could notice. Or again, for people that are extremely careful, when you urinate outside and then you visit your urine bag and you saw a lot of ants gathering around your urine, you might need to consult an health care provider in order for them to evaluate what's actually happening in the body. Thank you.
Thank you, Doctor.
You're welcome.
Yes, we still want to know, how can we tackle this disease, since it's a rampant issue?
Yes. In handling diabetes mellitus, there are 2 things that we need to view from 2 perspectives. The first one, which you call non-pharmacological perspective, yes. And then we have pharmacological perspective. For non-pharmacological perspective, we talk about education of the patient, we talk about the dietary modification, and then we talk about exercise. And all these 3 are very, very important for non-pharmacological management of diabetes mellitus. How do I mean? Education is the singular most important treatment modalities. The person with this issue needs to understand what he's having, needs to understand the kind of diet or the kind of modification that needs to be done to the diet. The person we are talking about needs to understand the importance of exercise towards managing this disease. It is not enough for you to just go to the hospital and you are giving drug, okay, take this one, do this one 2 times, do this one 3, or this injection, without appropriate education as to other lifestyle modification. Now, moving further, the issue of exercise. I told you about type 2 diabetes, that it's either the insulin is not enough or is not functioning very well. Exercise has been shown to improve the effectiveness of the pancreas to produce insulin. Also, it increases the potency of the insulin made available to actually perform the work is expected to do. So when you exercise very well, invariably what you are doing is that you are potentiating the insulin that you have in your body, or you are going to be making the drugs that will be using to work much better than without exercise. And this exercise we're talking about as prescription. It's not enough to just start running up and down, jogging and sweating it out all day. It has a prescription.
Yes.
Okay. For a moderate exercise, by moderate exercise I mean like jogging, okay, like cycling,
Yes.
okay, like some sort of swimming. By the time you do that one, 30.
What of a little trekking?
Now I'm still going to go to that one. That is not moderate. That's about the low intense exercise. Okay, but for the moderate intense exercise like jogging, like cycling, like brisk walking and all that, if you do that one 30 to 45 minutes, at least 3 to 5 days in a week, that's fantastic. But if you're just trolling, maybe because of old age or because of some other issues, I mean, just taking a walk, if you can do that one somewhere between 45 to 60 minutes, at least 5 times in a day.
Some people say
in a week, sorry.
The process of maybe a little jogging or whatever, you are burning the fat.
That's correct.
But what is the relationship between that fat and this
we said ab initio that diabetes does not only affect carbohydrates.
Yes.
It equally affects even the protein breakdown, the fat and oil breakdown, and other food nutrients breakdown. Okay, when you exercise and you burn some of these, what you are doing is that you are burning some of the excess glucose stored up as fat.
Yes.
In other words, you are burning it down, which is useful for the body. Even apart from the diabetes we're talking about, it's useful for the heart. It's also useful in the control of hypertension that an individual might have. Okay, so apart from the exercise, now we talk about diet. Okay, we try to run away. I mean, for people with diabetes, if they can have access to a nutritionist, that's fantastic. A nutritionist will weigh the man.
Yes.
We have an understanding of the calorie that this individual should take, and then they will break it down to day-to-day food stuffs that we eat. Like, okay, this is the number of things we should take and all that. But by and large, in the absence of that, we've gone beyond era of don't eat this, don't eat that. The era we are now, we talk about the quantity. We try to cut down on the quantity of food an individual eats. Okay, if you don't have access to a nutritionist, we ask them to clench their fist. So the size of the clenched fist will determine the muscle that you eat. Are you taking wheat, or are you taking eba, or are you taking rice? Since those are common food nutrients that we have here. So you get the size of the muscle about the size of the clenched fist, but there's no way this can fill the tummy. So we advocate for a lot of vegetables, that we bring a lot of vegetable into it, and fish. All this small food that we eat, we know there's no way we can make that individual to have a full tummy. So we advocate for snacking in between, snacks.
Yes.
And what are the snacks that we talk about? We talk about nuts, things like walnuts, cashew nuts, granuts. Okay, that for them to take, because by the time you take all these nuts, you'll be forced to drink a lot of water, and then you get the big tummy, or the sensation that, okay, my tummy is filled up. All right, as against just eating a very big bowl of food and then you're sweating it out, you know, like, I'm going to demolish this huge amount of, you know. We've gone beyond that. We talk about smaller quantity of food which you can eat in piecemeal, and then with a lot of snacking in between, a lot of water. Then in terms of fruits and vegetables, there are some of fruits that actually has high concentration of fructose, which is a form of sugar.
Yes.
So we tend to advise or counsel our patient to reduce such amount of fruit, things like orange. Instead of sitting down drinking a lot of that, we can ask you to divide it into 4 quadrants, and then just a quadrant is okay for the day. And then if you're taking banana, just 1 piece, believe is okay. But we need to eat something. Things like garden egg is fantastic. I mean, you can eat that one. Things like cucumber is okay, and things like carrots. I mean, those are some of the condiment, tomatoes, you know, that you can eat along the side. The other food, the reduced amount of food that we talked about. Then the protein, of course. In this part of the world, we have a lot of beans, so we advocate for people to eat that, not in excess too, with moderation. Okay, about the size of clenched fist with a lot of vegetables on it, so that whatever thing you're giving can work effectively well. So we talk about exercise, we talk about diet, and then the next thing are the pharmacological things of addressing this issue. Okay, we have so many drugs, there's no way I can be talking about drugs on here, but by and large, there are a lot of oral hypoglycemic agents, oral anti-diabetic drugs that people can take, and they are readily available, they are cheap. People shouldn't die of things like this. People should not develop a lifelong complication because of some of these diseases that could be well managed. People should not be taking all sort of how will I call it, herbal preparation that you cannot ascertain their efficiency, efficacy, and side effect of some of these drugs, for drugs that could be well and appropriately managed. And for those people that did not achieve control through oral drugs, we do introduce insulin. We have different type of insulin. We have the short acting, we have the intermediate acting, we have the long acting insulin, but depending on whatever the person is having, and that is what we determine the kind of treatment modalities that we give. But by and large, we advocate. This is a form of advocacy, at the same time a form of health promotion and education for people. If you notice any of these symptoms, do not sit down at home. Go to any healthcare provider. Let them examine you. Let them carry out some of these tests. And if you are diabetic, you could be managed very well because of some untold complications, which we'll still talk about.
Yes, thank you, doctor. Very brief, because we are out of time already. But I just wanted to talk very brief on the complications of this disease.
Well, there are a lot of complications that are associated with diabetes mellitus. I mean, you can start thinking about it from the head to the toe. Okay, but the common ones include blindness. Of course, diabetes has a way of messing up with the eye. We call it diabetic retinopathy. Of course, the person will start telling you, I'm beginning to have blurred vision, I can't see clearly. When I go, it's like I'm having cloudy vision. Of course, when you see that, it could be a complication of diabetes mellitus that is not well managed. Okay, yeah, people do have what we call diabetic nephropathy. Diabetes has a way of destroying some of the constituents of the kidney and can shut the kidney down. In fact, it's one of the commonest cause of chronic kidney disease too, and can make a mess of the kidney. Again, diabetes could affect the nerves of the body, which we call diabetic neuropathy. People will tell you, I'm having paresthesia. It's like something is crawling on my legs. It's like I'm wearing a tissue on my leg, whereas there's nothing on my leg and all that. Okay, all this could actually be a pointer to complications of diabetes mellitus. Also, we talk about erectile dysfunction, of course, in male, especially because of it could be due to two things: from the blood supply to the penis, and then from the nerve supply to the penis, which could be affected by diabetes mellitus at the same time. It could cause it. Then we talk about atherosclerosis, which can ultimately affect the heart, affect the brain, and all sorts. All this could be complications of diabetes mellitus. Again, earlier on, I told you that some people, the first time they are aware that they're having diabetes is after they fainted at home, or they became confused and they rushed them. Okay, those are another complications of diabetes mellitus, which we call diabetic ketoacidosis and hyperosmolar hyperglycemic states, because the sugar will be in excess, find its way to the brain, cause all sorts of things, and then the person will faint, and that is when they will rush that patient down to the hospital for evaluation and then the other treatment. But before this could happen, I've told you, because of the nervous affection by the diabetes mellitus, it could actually destroy some of the nerves and the blood vessels supplying the leg, leading to amputation, leading to what we call diabetic foot. When they have wound, the wound will not get well, and then the leg will start dying. And a dying leg is very useless to the body, leading to what we call amputation. So it is in the modern day now, it is not a good thing to hear of, that people are losing their limbs, they are losing their legs because of diabetes mellitus, which can be treated effectively well. If you ask me for my advice would be, let's individual and group of people go for routine medical checkup, even if it's not more than twice in a year. Let them run all these tests for you, and if there's any issue with any of the system, we can know early and institute appropriate treatment early before all these complications will set in. Thank you very much.
Thank you, doctor. Yes, viewers at home, drawing the curtain of this program. With me on the program is Dr. Adeleke. It's nice time having you on the program.
You're welcome, sir.
I'm Ayobami Salako, and behind the camera is Tosin Adedokun. If you have any question to ask, you can just drop your question, lines, or the address that is going on the here now. Till next week, when we shall meet. Bye-bye.